Good afternoon. My name is Peter Lohuis, and I was asked by TradeMed, who is the official distributor of Somnodent, to give a lecture about the current position of mandibular advancement devices, MAD, versus CPAP in the treatment of apnea. So the lecture will go fast sometimes, but I hope I can be clear about this subject. Now, what is sleep? Sleep is a reversible state of unconsciousness, so it can flip on and it can flip off. Sleep is an essential physiological process that appears to be important in homeostasis, which is cleaning up the brain in a sense. And sleep patterns, so deep sleep, dream sleep, and sleep requirements, how much sleep do you need, change as we age. This was a question on the course that we were giving, and all three are actually true statements. Now, why is sleep important and which are its functions? Now, what you see here is that you have all these brain cells which shrink during the night, which increases the fluid in between, and here you see that all the garbage materials are disappearing towards the vein. So it's a restoration of homeostasis. This is called the lymphatic system, the same as our lymphatic system, and during sleep it just gets rid of all the waste products. And the main goal of sleep in a neuroscientific point of view is that it gives a restoration of the homeostasis of all the information in the central nervous system. Now, why is sleep important and which are its functions? Well, during the day you have problems during the night, but during the day it's important for emotional state, so social behavior and mood, for cognition, how fast you learn, your creativity, your memory, your physical health, because long-term apnea or other sleeping disorders have an effect on, for example, vascular disturbances like stroke, heart disease, hypertension, but also diabetes. And what some people don't know is that also immune function is severed with poor sleep. So it has an influence on cancer. In mice, it has been shown that 30% of the sleep-deprived mice have 30% more chance of cancer. How do you classify? When you want to talk about sleep, you have to classify it. How do you classify sleep disorder? Well, there's insomnia, which is you cannot sleep enough, you're worrying. You have sleep-related breathing disorders, you choke, which is, for example, apnea. Sometimes you sleep too much, which is a genetical disease. There's rhythm disturbances, for example, jet lag is a rhythm disturbances. People who travel a lot have these rhythm disturbances. You have parasomnia, which is, for example, nightmares, or you start acting on the nightmares. And you have movement disorders, so you move a lot and the brain wakes up because the body is moving and it's an arousal. In this lecture we talk about apnea, so that's a breathing disorder during sleep. And what happens is, which you see here. Here you see the tongue, which is now in a tension state. But when you go to sleep, especially when you're in a dreaming sleep, everything relaxes and the pharynx, as it's called, will block because the tongue is dropping backwards, and this will get also a little bit floppy. So what you get is the tension in the tongue reduces its strength, the airway is collapsing, the oxygen drops, the brain notices that the oxygen drops, so you get an arousal in the brain activity. Then the tension in the tongue is restored, it moves forward again, you start falling asleep again, but then you lose the tension in your tongue, the airway collapses, oxygen drops, and your brain wakes up again. So it's continuously waking up of the brain and falling asleep, which reduces the sleep quality. Now, that will give a poor quality sleep, which is fragmented, but also will give a drop of oxygen all the time, which we call oxidative stress. So, and the vessels will start reacting to it in the long term. Here you see that the trachea or the air pipe is very stiff, that the nose is stiff. It both can have an influence on this area, which is collapsible and called the pharynx. And tongue is part of this area, and it has a critical closing pressure. That means at a certain point it's just too much and the area collapses, and that will differ between everybody. Some people have a very collapsible pharynx, or a very big tongue, or a very small jaw, and all these factors are important for when does this collapses. So that is summarized here. What are the risk factors for apnea? Here you see anatomy, so that's purely how it's built. The jaw can be small, the tongue can be big, there can be a really elongated uvula, for example, large tonsils for kids. When they have large tonsils, they just get together. It's called kissing, and suddenly the child cannot breathe anymore. It wakes up and is sick as a result of it. Aging, so especially for women, after the menopause, everything is collapsing a little bit more. Apnea increases and they kind of catch up with men. Overweight, when people are very heavy, there's also more fat next to the pharynx, and it will easier collapse. All right, so we're talking about nighttime problems, so that's snoring, breathing stops, and fragmented sleep, and daytime symptoms. So there's daytime fatigue and sleepiness, there's morning headache, there's a decrease of reaction time, and also memory and intellectual impairment. Plus the comorbidities, because of the oxidative stress, it has an effect on the endothelial cells of the vessels and will give long-term things like stroke, cardiac problems, high blood pressure, resulting in death maybe. But also, though apnea is usually the indicator of this huge traffic accident. People just fall asleep behind the wheel and suddenly move to the other lane. Depression, some people are on antidepressives from the family practitioner, but if you ask them very well, they just cannot sleep during the night, and that's why they're in a bad mood. Hormones can differ. There's a lot of things that are related to apnea. For example, also impotence. Is it true? Well, there's so much literature on this subject, and here you see a study from the Lancet where you see that the risk of all these cardiac problems and vascular problems are increasing with the amount of apnea that you have. And is it a lot of people? Well, in the USA there's billions of dollars spent on increased health as a result of apnea, as is published by the American Academy of Sleep Medicine. Here you see another slide where it shows that all these things like hypertension, stroke, heart disease, coronary disease, defibrillation of the so rhythm disturbances of the heart are all related to apnea in a certain way. Now, how do we measure apnea during the night? Well, there's something which is called polysomnography. It's a test where you go and measure airflow, oxygen, heart rate, rhythm, and also brain waves at the same in the same procedure. Actually, what it does is it measures your sleep and your related oxygen and breathing capacities during the night, and gives you a report about that from which you can draw conclusions. And what you measure is apnea, hypopnea, or an arousal of the brain, which is related to breathing, because you can see that the oxygen will drop more than 3%, or that the airflow will drop significantly. In the end, you add up the apnea and the hypopnea and you measure them per hour, and you combine them with the oxygen desaturation. Sometimes you see people drop from more than 10% or even 20% during the night. Now, how big is the problem? In the Netherlands we have 17 million inhabitants, and it's estimated that 2.4% of the total population is having it. It's diagnosed less because it's also there underdiagnosed, but a lot of people are there treated with the CPAP mask or with the mandibular device, so you kind of know their numbers. In Croatia, we're talking about 4 million inhabitants. I think it's completely underdiagnosed because there's only a few thousand people who get the diagnosis. And in the Asia region, there would be probably 700,000 people suffering from apnea. Also there, the diagnosis will be a lot less. How can you treat it, apnea? Well, in 1981, Dr. Sullivan came up with the CPAP, which gives continuous pressure during the night. So actually the whole pharynx is blown open. It was an excellent treatment, and it has saved a lot of patients. Here you see different ways of breathing devices, which are also used in intensive care. There's a whole set of them. But you have to wear it, of course. If you don't wear your CPAP device, it's not working. And what you see that people tend to not wear it because it's not sexy. Do I have to wear this the rest of my life? Yes, you have to wear it every day if you want to treat your apnea. They have difficulty, so they tear it off while they're sleeping. And in the end, 30 or 40% of the patients have problems. So, is it efficient? Yes. Is it effective? Well, is it effective? Yes, but is it efficient? You don't know, but you have to, because you have to wear it. So in the end, they state that you have to wear it more than 4 hours per night and more than 70% of the nights. And in reality, that seems to be less. What we are saying is that there could be more individualized treatment for apnea patients. First of all, you have to diagnose them. A lot of people are running around undiagnosed. That's one. CPAP is a very good treatment, but you have to wear the mask. And what we see in the Netherlands, that there's also other ways of treatment, because we try to personalize the treatment. First of all, there's a mandible advancement device, which you apply to the teeth. It brings the jaw forward, and therefore also the tongue, which will give you an open airway. There's surgery, which became better because we have a barbed wire now, so now you can attach the tissue on itself. It opens up the palate, the area behind the palate, and it will strengthen the palate, so you get decreased snoring, but also a decreased apnea. And sometimes you can combine it. So why not combine the MAD with surgery, like you sometimes combine the CPAP with MAD. When the epiglottis gets very floppy, the CPAP doesn't work anymore, you bring the epiglottis forward with the MAD. So you can also combine the treatment. In the end, as they came up in the USA with something which is called hypoglossal stimulation, you do a coil around the nerve, a sensor at the lungs, and whenever you breathe in, you kind of stick the tongue out, which is comparable with a tension in the tongue. It's beautiful, but it's very expensive, so only 100 are being done in the Netherlands each year. And it will come to Croatia, but I don't think now there's still a place for MAD at this moment. Because that's the problem, I think, in Croatia a little bit. We have CPAP, and it's the only thing that you know, and then you use it for all the patients, but when they don't wear it, you have nothing. And in those cases, you have to kind of individualize and try to look for an alternative. Now, here you see the whole schedule, what you can do based on anatomy, questionnaires, symptoms, etc. You measure how many apneas and hypopneas there are each night. They can be 5 to 14, and in the Netherlands that's considered mild. There can be 15 to 30 an hour, which is considered moderate, and there's more than 30 which is considered severe. Now the treatment is kind of related to how bad it is. For the mild and moderate, you use a mandibular device where you try out if it's possible, if they have good teeth, because it has a strain of the teeth. Barbed wire surgery is a possibility, but of course also CPAP. If they like the CPAP, it will blow it open. It will be perfect treatment all for the mild and moderate cases. Here they usually go for CPAP because you can measure whether it works with a chip. But sometimes there is intolerance, and in the Netherlands then we shift to the hypoglossal stimulation, or we shift towards a combination of the MAD and the surgery. Same is for snoring. It can be related to apnea, but if there's no snoring, you know, no treatment. But snoring will also be well treated with the MAD because it will bring it forward, it will be less negative pressure. How does a mandibular advancement device work? Here you see it. It's fitted to the teeth and thereby brings the lower jaw forward, When the lower jaw is brought forward, the tongue will also be brought forward, and there will be a continuous open airway during the night, just by changing the anatomy in a way. Here you see how it works again. Here it's obstructed, here the jaws move forward, and it gives continuous open airway during the night. Is there proof that it works? Because that's always the question. Well, there's so many studies, and they're randomized and controlled, and it works. And in some cases it replaces the CPAP and is good enough. In some cases you can combine it with surgery, but it will reduce the AHI, and it's measurable. You can put in the mandibular advancement device and then repeat the polygraphy, so you have proof that it works. So all this has been measured, and that's not an issue anymore. It works. It's just a matter of, all right, which device is the best? Is it SOMNOMED or is it the competitor in these cases? Here you see that it is true that in some cases the CPAP is better, so it's more efficient, but the compliance is better for the MAD, so they wear it better. So in the end, you can end up with the same result because it's being worn better during the night. How can we measure if there's obstruction in the OR? Well, you can do make a tape of the airway during sleep. So you give a shot of anesthesia, people fall asleep, and just while they wake up in that stage, you see how the airway opens up, where the snoring takes place, and at which level the obstruction takes place. So especially when you want to go for the surgery, and then this really helps to show you where your surgery should be done. Should it be at the breathing valve, or should it be at the palate, or rather at the tongue, for example? Does the surgery work? Here you see an example. These are the tonsils. This is the uvula. This is what you call the palate. And here you see after the barbed wire surgery, which looks like this. You can string the tissue on itself, that the area behind the palate actually opens up. And you see here there's more space. And you can imagine that the negative pressure has been decreased now very well. And here you see the data. This is the AHI, so the combined apnea and hypopnea before surgery. Here you see it reduced after surgery. It's still higher than 10, but it's not the 45 anymore on average. And you see that after this, you can still do a mandibular advancement device to get rid of the last 10 apnea. So it's a combination of therapy, it's individualized therapy. Here you see this beautiful piece of technology with a sensor at the lungs. Here's the pacemaker, and whenever you breathe in, this coil, which is around the part of the nerve that sticks the tongues out, is firing in order to give more tension in the tongue and opening up the airway behind the tongue. Beautiful, but I hope that we can be the first one to apply it in Croatia, but the company doesn't even want to do it because the measurement should be better off in the complete country. Right, now when you decide for a mandibular advancement device, which one do you use? There are many there, boil and bites, that means that you can do it yourself, but the problem is it has a strength on teeth and it should be a good one. Well, I was asked to give the lecture for TradeMed. They are the distributor of SOMNODent. They have 3 types, and this is the most advanced type, which also has a sensor in it very soon. And the quality is excellent, it's durable, there's a warranty for a few years, just like with CPAP. It's easy to wear, the coating, everything is patented, it's just a very good device. And you can actually, as a dentist, not make this device if you have a company which worldwide serves as a distributor and makes these fancy things. TradeMed is distributor in the Asia region. It is not so popular, but they're trying to popularize it. In the end, it's connecting the dentist with the ENT neurologist that diagnose the apnea. it's convincing the specialist that SIMPTOMI is the best MAD for the money, which I think it is, and create a system with specialized dentists in Croatia so that patients can actually obtain this device quite easily. That is not an effort. SIMPTOMI is a company in Australia which started this device. I think it's a technical dental company in the base. It was founded in 2004. They have an office in America in 2006, but they're all over the place, and more than 500 patients in different countries are wearing this device. It needs to be applied by a certified dentist. And why? Because the teeth need to be checked, and of course it has a strain on the teeth because it brings the jaw forward, and somewhere that strength has to come from. Well, that's by dividing it over all these teeth. Here, for example, you see poor teeth, all this is checked, and also here you see that the new position of the jaw also has an effect on the joint, so also that has to be taken care of. Boil and bite, no, because then in the end it will work a little bit for your snoring, but it will also destroy your teeth, so you have to go to a specialist. This is actually how it works. Your specialist fills in this form and sends you to a dentist which he's connected to in different places in the country, and then the dentist will do the bite for you and help you with the device and make sure that it's set in an appropriate way. Is it reimbursed? Well, not yet. TradeMed is busy with that. Yeah, it's just making the insurance companies aware that it's there and that it works, as you see the proof. But in the Netherlands it's been used like many times, and especially for the mild and moderate apnea, it's the first choice in these patients, especially when they're young, because they don't want to sleep with a mask all the time. So, to conclude, now we are 37 years past the time that CPAP was invented. It works perfectly, but there's a few innovations. There's the sleep endoscopy, so you can see where the obstruction takes place. There's the barbed wire pharyngoplasty, so there's a surgical option now. There's the very fancy hypoglossal stimulation device, which is also very expensive, of course. And there's the mandible advancement device, which in the end is just as expensive as the CPAP, but it's just an alternative. If you don't want to sleep with a mask, you have something else now to help you with your apnea and the consequences of this apnea during the day and long term for your oxidative stress. All that is being now popularized via the Croatian Apnea Society because it's a new thing, and new things take some time to be applied, and they are busy now with overcoming that. Okay, so thank you very much. I hope this lecture helped you, and thank you for listening.